yet or not. I'm gonna see if I can get onto my other computer and see if, okay. Oh yes, sweet. Okay, yes, I can see myself. Okay, so I'm gonna sit here and wait for a few minutes and then I will just randomly start talking. That's funny, I'm on both computers and I've just realized that there's a delay in the other one. Hello, good morning. Good morning. Or good evening, wherever you are in the world. That's really weird that there's that delay, but that's okay. My mother, my world says hello, hello, good morning. Okay, good evening. Whereabouts are you? Where are you in the world? It's so funny. I'm used to giving from Zambia. Oh, that makes me so happy. I'm used to giving from Algeria. Marhaba or bonjour. I'm used to giving talks on Zoom and stuff, and you're able to chat back. I wish there was a way to do that. Hi, Mississippi. Hi, Romania. I wish there was a way to do that on from Sri Lanka, from Nigeria. How great is this? On this live chat where we could actually just kind of talk through, like you could directly ask questions instead of going through on this chat. Northern Ireland, you're so welcome for these videos, and I'm so happy you're watching from the UK. I grew up in the UK. Everybody always asks me that, why my accent is like this, but I grew up in the UK till I was 16, and it was apparently very formative because in the US, everybody still thinks that I'm 100% English. And then it's funny, obviously, when I go to the UK, people can hear my American accent, but people, like, there's so many people, hi, Humayun. There are so many people that I work with who have just joined the unit that I'm in, and I'm in Texas. We're not really supposed to say a lot of details about where we work and everything, but I am in Texas. And so sometimes like night nurses or somebody who's just joined the unit will come in and, you know, my hair's up, I'm always in scrubs and no makeup or whatever. And I start talking and they're like, oh my God, what's your name? And they can't believe that, like, you know, that I'm Tala from, you know, the YouTube channels that they may have seen or whatever. Everybody just assumes that I just don't work in America. Hi, Lusaka, Zambia. Wow, really from all over the world. So I had questions from you all. So somebody's asking to talk about neonatal hypertension. I am planning on doing that as a separate type of video. I want this to be a lot briefer and back and forth with kind of like more acute questions about, if anything, commonly asked topics, common symptoms and stuff. You know, hypertension generally is pretty rare. We do see it though, and we do have to deal with it. So I am actually kind of halfway through writing a video on that, so I'm not going to cover that. I did have a list of things that I did want to talk about, and I had it on paper. Oh, here's my paper. These are questions that I've received just generally. Oh, there goes my computer. I'm carrying coffee, as I always am. So these are questions that I've just had generally, but if anybody wants to interrupt and ask their own question, do that. But I figured that, like, I should have something in the background to talk about. So one of the questions I think I've already covered, where do I work now? I work in Texas, and actually in Dallas. I wonder if I'm even allowed to say that. And I work in an absolutely fantastic practice with just the best group of people, nurse practitioners, nurses, doctors, in fact, just the whole unit culture. And, you know, I do just want to bring this up quickly. I have moved several times, and honestly, I've really loved a lot of my jobs. Really, I think I was lucky being in this field that I do really like. I will say though that I feel like the unit culture is so dependent upon leadership. Like not just the doctor's leadership, the nursing leadership, the leadership even above that in the hospital, like the CEOs and whatever, how much they just let you be and figure out stuff and, you know, support you and everything really makes a difference. And somehow I've landed in this unit where there's very little turnover. There's been a bit more since COVID, like every single hospital in the country, but just low turnover. A lot of the nurses in the hospital wear badges that say how long they've been there for. So like, you know, 20 years, 25 years, 10 years. And that's just a really healthy place to work when people can choose where they want to work and they can watch anywhere. Hi, good evening, Greece. How are you doing? So for anybody that's just joined, you can feel free to ask any questions. If it's a video that I've already got planned or I've basically already talked about, okay, Rima Tom is asking for emergency drugs in neonates during intubation, and we can cover that if you want. I always find this really interesting actually where NRP has landed. So NRP, as you all know, is the neonatal resuscitation program. And I feel like it's tightened up so much in the last few years, in the last few editions, especially with like the amount of drugs that we use. Really now, the only drugs that NRP actually encourages using to bring back a baby in a code to actually resuscitate a baby is basically epinephrine, whether it's endotracheal or IV, normal saline, or packed red blood cells. Really, there isn't really any other, you know, indication for other drugs. Outside, if you do have a code in the unit, then obviously we can end up using, you know, a lot of different drugs. And interestingly, like in the last 20 years, that's changed a lot. For example, Narcan or naloxone used to be part of NRP. So that was like when we had, if a baby came out really depressed and you're worried that they were really depressed from like a narcotics overdose, then one of the tools that we'd have is like literally giving IM Narcan to try to wake the baby up. But I think everybody can realize why that was no longer encouraged. And basically the issue there is that you're worried that this mother has been on narcotics throughout the whole pregnancy, whether she was on prescription drugs or whether she was using recreational drugs. And so if you give Narcan in the delivery room, you might just, you know, tip them over to a massive withdrawal and they could seize. So we stopped doing that. Also, bicarb has had a very interesting history in emergency drugs. Sodium bicarbonate, that used to be a part of just the general resuscitation. And then, you know, more and more people were kind of like, well, it doesn't really do anything, sodium bicarbonate. When we're giving it, especially, you know, in cases of acidosis, all we're really doing is, somebody just retracted a message. I don't know what that means. When we're giving sodium bicarbonate, all we're probably doing is just making our cells feel better. We want the cells to no longer be in an acidotic environment. So just giving sodium bicarb may make the pH slightly higher. And I will get to that, Humayun, maybe making the pH a little bit higher, but might not necessarily be good somebody's just asking about Lisa and about medications that we give for intubated babies. I'll just spend like a minute more on these resuscitation drugs. Anyways, sodium bicarbonate, people will adamantly say that it's not really helpful. As you can imagine, it's almost impossible to prove how actually helpful a drug is in a code. Nobody's going to want to do a prospective trial. Like, you know, there's a lot of lack of equipoise, which means that the doctors that use it or the teams that use it are convinced about using it, and how are we going to consent that? So it's very, very difficult to actually get trials to figure out which medications are used or shouldn't be used. I will say from my own experience that, first of all, it has been suggested with bicarbonate that when the pH is really, really low, then that starts affecting heart contractility. Maybe it's less than 6.8, I'm not sure. So it is suggested maybe in those situations, giving bicarbonate is actually helpful. I have been in a case where, quite recently, where a baby had profound acidosis and profound hyponatremia. And we ended up giving this baby sodium bicarbonate, and it kind of seemed to like hit two things, that we were giving, correcting for the sodium and correcting for the acidity. And I actually think that's something that got the baby out of it. I think really what's happened in the delivery room is that everybody is just putting more and more emphasis on making sure that we have excellent oxygenation and ventilation. Like, the most important thing that we do is making sure that we're breathing for the baby. And so, in a way, it's taken away all these meds. Like, we don't really need these meds. Maybe epi will help to kickstart the heart. Or if we're like extremely hypertensive, we need a normal sodium bolus or packed red blood cells. But really, if a baby is decompensating, more than 9 times out of 10, whatever the statistic is, it's nearly always the lungs. And the lungs then affect the heart because the heart isn't getting enough oxygen. So sometimes you have to kickstart the heart, with the epi or whatever. But really, the NRP emphasis is on making sure that we've intubated, that we're giving excellent positive pressure ventilation. And I think that's what's kind of where we've moved forward that. We also used to give calcium as well, hoping that will kind of stabilize the heart as well. So really now NRP is a lot simpler. Make sure that you're breathing for the baby, and if you need to, give epi and the other drugs. Okay, a couple of other questions that were asked. One of them was the medications during intubation. I think, hi, Northeast India. One of the medications was, which medication should we be doing during intubation? First of all, we, 25, 30 years ago, there was honestly the understanding that babies were not, hi Sanjay, that the babies were not, aren't able to feel pain. Like, they were actually, this was kind of came down not that long ago, like we're talking 90s, that babies literally didn't have the pain receptors to be able to feel pain. And so it was like a pretty big shift in neonatology when people were like, oh, actually babies probably do feel pain and we don't want them to be in pain. And then I think we got maybe a bit liberal with the drugs, whether it was the narcotics, whether it was with benzodiazepines, so like a midazolam, or narcotics, like whether it's morphine or fentanyl or whatever. And now I think where we've kind of ended up is that really a lot of those times we know that it is not good. Like, keeping babies on morphine for a long period of time, fentanyl for a long period of time is not good. The way that it affects their brains, the way that it affects like their brain development. And we've seen studies where we followed up babies on, thank you. That's a nice thing to say, Hamza. So we followed these babies up, and we know that babies that are on morphine or narcotics for a long period of time, that does actually affect their overall development. Same thing with Versed. Now more data is coming out, and I'm actually going to speak to somebody who's kind of been investigating this further about there really is a NICU delirium type place. Like, we know in adults, there's something called ICU delirium, where adults, when they're put on, benzos and on narcotics or whatever for a long period of time, it makes them delirious. They aren't thinking rationally. It's just not good for their overall neurological status. It takes them a lot longer to rehab out of the ICU, out of it. So I think in everything, we're realizing that the less drugs that we can give, the better. So we do have different pain scores. And remember, there is a difference between pain, where we definitely don't want babies to feel. If a baby has had a surgery, if a baby has a chest tube in, if we can objectively say that this is a painful procedure, obviously we should be giving pain medication. So whether this is a narcotic, whether it's a non-steroidal, rarely used in the NICU, more commonly we'll use Tylenol, which works very well as a pain medication from an actual procedure or whatever. And we can give Tylenol enterally or rectally. We can also give it IV. Apparently, it's one of the most expensive drugs on the planet to give Tylenol IV. I found that out pretty recently. But that also works very well. So we do not want babies to be in pain. Categorically, we don't want babies to be in pain. The question is do we routinely have to be giving babies medications if they're intubated? Should we be considering that as a form of discomfort? Like I said, there are ways of figuring out whether a baby is in pain or not. We have pain charts, where, we can objectively look at the blood pressure, the grimace, all these heart rate or whatever, and decide if this baby's in pain. If the baby is not in pain, we really don't want to give pain meds or sedation. Sometimes we're in a situation where, for example, the baby is on the oscillator and really, really fighting the oscillator and just not letting the gas exchange take place. And we're on really, really high settings. We can barely oxygenate and ventilate the baby. Yes, sometimes we're forced to sedate that baby. Sometimes we're forced to literally medically paralyze those babies in a desperate attempt to get the babies to oxygenate. That is a last ditch effort. Once you're paralyzing a baby on a ventilator to try to oxygenate, you're in a very vicious cycle. The second that you're, medically paralyzing them, which, by the way, never ever do that unless you're very sure that the baby is very well sedated. But once you do that, the babies have, increased fluid accumulation just because they're not moving as much. It's not good at all. So really, my point is that we are trying to avoid medications as much as we can. If you're forced to do it, then yes, give small amounts as briefly as possible, basically, and try to wean off as quickly as possible. If the baby is on the vent and you really feel like the baby is uncomfortable and really, really needs it, then yes, you're in a situation where you're kind of forced to give something. But also consider, can we change the ventilator that the baby's on? If the baby is fighting the jet and is a couple of weeks old, can we put the baby on the conventional ventilator and then not have to sedate the baby? I would prefer to do that if we can force that rather than to give medications to keep this baby on the jet. I don't know if that kind of covered it. I can't remember who actually asked that, but did you have any more questions about that? I am going to chat with somebody about the whole concept of ICU, NICU delirium, which I think we haven't really really established as a topic that much in the NICU at all. So I think that's going to be really interesting. We've all had these babies that we've had them on fentanyl drips or whatever. And we've seen the way that it affects those babies. I just got a really nice comment. Your mandatory viewing. Oh, and now I've lost it. It kind of goes on for a second and then goes off again. So I'm just going to look at it here. Your mandatory viewing for all my orientees, been doing NICU for not quite 30 years. And your resource has been one of the game changers in how I approach complicated NICU topics with orientees. Oh my God, thank you so much. What a lovely comment. I have been off I'm now feeling teary. I've been off for the last few days and I've been away from the NICU and it's been really, really busy in the NICU and a couple of not great things have happened in my absence. It's so tough, this field. It's hard and I've kind of been feeling a little bit emotional all day as well. So anyway, thank you very, very much. I love that we can all support each other this way and we all kind of realize that good things and bad things happen and we just have to be there for each other. But I really needed that lovely comment today. So thank you, CHS Matt. I don't know what your full name is. The Bowel Chronicles is a fantastic name for a name on YouTube. That's funny. Okay, so there was another question that somebody just asked now and I can't remember what it was about. Not intubation, not drugs. If you have more kind of shortish questions like that, I'm happy to ask. Otherwise, I am going to, Lisa, sorry, it was Lisa, yes. Hi, Poland, how are you doing? Lisa, so that is Less Invasive Surfactant Administration, which has kind of been sweeping neonatology. Quick cup of coffee here. This says, love me, love my dog. This is how old it is. My Lovely, lovely, lovely dog. Passed away a couple of years ago, and like I feel whenever I hold this, I'm a bit closer to her. We haven't gotten a new dog yet, so I've been pushing my husband for it, but he's not quite ready, but hopefully. Okay, Lisa, less invasive surfactant administration. So this is a technique where we're hoping that we can administer surfactant, whether the baby has RDS, whether the baby has meconium aspiration, whether the baby recently had a pulmonary hemorrhage and we realize that the baby has very poor, that the blood has inactivated the surfactant. Normally they're intubated if they've just had a bloody hemorrhage. Or for example, sometimes babies have really bad amniotic fluid aspiration and they need surfactant. So I don't have to go over that. You all know that babies sometimes need surfactant. So it is a way of giving it without actually intubating the baby. So what we're doing is you use generally a really skinny catheter. So we use really kind of like an angiocath thing. You measure out how deep the angiocath has to go, and then you intubate. So you're still using the blade, and then you intubate the angiocath to the depth that it's supposed to go. Once you're intubated, and recently we started using the TCOM, so the CO2 monitor that changes color, you can actually attach that and see the color change. You know, we used to kind of suction out halfway through or whatever and make sure that, you know, we really were intubated. But this is a way of making sure that we're really in the same place. Once you have that skinny little tube in, you can then push the surfactant down the catheter, and then you know, we normally give it in a couple of doses, and then you pull out the angiocath, and then that's it. So there are a couple of advantages to this. The first one is that the baby is normally going to be on CPAP or a high flow nasal cannula or something as you're giving it. You don't have to take the baby off the high flow nasal cannula or the CPAP as you're giving the Lisa, because it's just, you're pulling it back, it's just a little, you're still using the blade, but you can keep all the equipment on. So that's the first advantage, which, you know, if you look at some of those trials, generally babies do a lot better when they're still on, when they were put on the high flow nasal cannula. You know, the trial out of Australia, when they were given 10 liters of high flow as they were trying to intubate, there was a higher proportion of intubation. Bonjour, Belgium. Although I don't know if you speak French in Antwerp. Thank you so much. Thank you, Rima. That's one of the advantages, that you can keep the baby on the support that they were on. The second advantage is that you are not intubating the baby. So I know that that sounds silly, but think about the number of times you've had a baby who's like 27 weeks, right? And you go to intubate the baby, you want to give surfactant. So the baby's on 35% or whatever. Oh, sorry, Flemish. Yeah, I figured Antwerp was like that, sorry. So you intubate the baby, you give surfactant, and then how many times has it happened that everybody is like, you know, the babies kind of get a bit depressed after it. It takes a few minutes or whatever for the surfactant to start working. And so then you're like, I probably don't want to take the endotracheal tube out. And you keep those babies intubated. Probably don't really need it. Maybe you just need to give them a couple of minutes, but you're like, oh, we're in, we don't want to push it any longer. So I think, honestly, this is the best thing about Lisa, especially in the preemie babies. It doesn't give you any incentive, obviously, because it's a little catheter. You're not intubated. So you are not, you know, going to keep that tube in because you can't. So even that is very advantageous for babies, pulling out that tube. You know, the third thing is that as you're giving the, I need both hands for this, as you're giving the surfactant down the little skinny tube, it's down a syringe. You are not giving positive pressure ventilation. Another positive thing. So normally when you're on the vent, you're giving the positive pressure ventilation. We know that literally every single time you give positive pressure ventilation, you're probably causing a tiny bit of barotrauma. And we've all seen what it's like when we're actually pushing in that surfactant. Sometimes we go higher on the pressures. that's not good as well. So the mere fact that it's just kind of like, you're pushing it in with a syringe and then it's allowing to kind of trickle down to the alveoli, and I'll talk about that in a second, is probably advantageous to just the lungs. There are studies that show that just getting a few big positive pressure breaths in the delivery room puts babies at increased risk of BPD. So anytime we can avoid positive pressure, if we don't really need it, that's a good thing. The other advantage is, you'd think that just because the angiocath is a lot skinnier, you're going to cause less trauma around the vocal cords and the trachea or whatever, just because it's a little angiocath compared to the endotracheal tube. So in that way, yes, it is less invasive. Okay, somebody's asking, how do you prevent the reflux of surfactant during LISA? That is a very good question. Yes, less pneumos with less positive pressure as well. I'll just get back to that in a second. I was just going to say that, it is definitely less invasive. We are not intubating babies with an endotracheal tube. We're less likely to keep them in. However, it's still pretty invasive if you are a baby. I mean, you're still doing the blade, you're still shoving it in, you're standing over the baby, there's a couple of people around you. It's not quite there yet. And I think that this is a work in progress. Going back to kind of, and I think hopefully eventually, hi Shireen, what a lovely thing to say that you're happy and proud to be part of this community. Thank you so much. So I think eventually we will get to even better abilities to be able to give the surfactant, which maybe hopefully in a less invasive way. Some places are using the laryngeal mask, the LMA. What does the A stand for? I'm blanking now. So a lot of places are giving the surfactant down that way, where you're not really intubated at all. You can use positive pressure with that. So that feels like it's a lot less invasive. Honestly though, we barely use LMAs as well. Next step is a small flexible camera that can give the surf. Yeah, maybe that we're just not using the blade and stuff. I think that it is a step in the right direction with airway. So I think that unfortunately the nebulized types of surfactant was tried, and the problem with that, hi Felipe, the problem with that is that the surfactant, it just didn't work as well. The surfactant when it was nebulized was just not getting down into like all the alveoli. And by the way, I think, and somebody said this, that sometimes and this has happened to us as well a lot, that sometimes the last kind of vestiges of surfactant comes back up that tube, or the baby coughs it up and it's in the mouth a bit. I think that there is a situation where if babies are are needing surfactant, if their lungs are completely collapsed, like they've got a whiteout, I personally, again, personal opinion, I don't think that these are babies where squirting in the surfactant with a syringe like we do in LISA works as well. Sometimes we need that positive pressure to literally open up the lungs and to be able to distribute that surfactant into the little end of the lungs. Remember though, even if a little bit of surfactant is coming up the end, depending on what you use, we use CuraSurf, which is like 2.5 mLs per kilo. That really is, you're still getting, maybe 2 mLs per kilo or whatever else. Remember that those studies were done on those doses. And, a lot of times you're going to have a lot of benefit, even if you're not getting every single last drop of that surfactant. Sometimes we try going a little bit slower, so we squirt it, generally we squirt it in 2 aliquots to try to kind of like get it in to Sujith, welcome to Feed a Grower. I think he just joined as one of the members. I've never seen that green thing before, but hi. I'm going to talk about that in a second. Yes, so sometimes we are getting a little bit squirted out, sometimes kind of giving it slower. But honestly, sometimes I've seen babies that are so collapsed that like we just can't get the surfactant all the way through. This is especially true if you've got one side of the lungs collapsed and the other isn't when you're still on CPAP. That's really concerning that all the surfactant is going to go to the side that isn't collapsed. So we're not quite there yet. I think we've all realized this is definitely a step in the right direction. I mean, I've said this in a few videos before. I've said it on lives that, you know, we used to intubate everybody. You know, the meconium aspiration baby, sorry, not the meconium. If a baby was born through meconium in the delivery room, we'd come out and we just intubate them. We intubated preemie babies. I mean, babies were getting intubated left, right, and center. Probably not a good, definitely not a good thing for the babies. And I think we've really gone the other way. And now we just have to keep figuring out how to do all of those. Felipe is asking me the FiO2 limit to use surfactant. I feel like this has also been changing as well. You know, I think when we all kind of started, we were like 35% now. You know, and I think that that's kind of come down. You know, in a 27-weeker with who's working really hard to breathe and the x-ray looks like really bad RDS, then I would give that surfactant a lot lower. In our practice, we kind of say 30%, but I'll tell you, you know, the boys that really scare me, it's the boys who are like 36, 37 weeks old with RDS. I feel like that population is such a high risk of getting pneumothoraces. So honestly, if those babies are tugging away and they need CPAP and their x-ray looks like RDS, I'll give them the LISA at less than that, at like maybe even 28%. So I think, you know, obviously your practice should have your criteria, whether it's in and out surfactant, whether it's surfactant for any reason. But I also think we need to look at other things as well. We need to look at the level of FiO2, not just the level of FiO2, the work of breathing, what the x-ray looks like. I had a baby a couple of years ago where the mother was like, their older brother ended up having, like at the same age, it was like 36, 37 weeks, ended up having multiple pneumothoraces because of really bad RDS. I'm not gonna wait around to give that baby surfactant. I mean, I think we ended up giving that baby surfactant like 25%. The x-ray looked like really bad RDS, and I'll come back to that, Magdalena. And we just gave it. I'm not going to sit around thinking, okay, clearly genetically these babies are predisposed to get pneumothoraces. So yeah, we just gave it at an even lower FiO2. Sometimes I do worry about like saying this stuff. Obviously, some of the stuff that I say is my own opinion. If you look through, you know, every single paper and study, it's going to give you probably higher FiO2 levels. I think this is probably one of the huge things that I've learned working, you know, and I am in a private practice working for 17 years, that, you know, a lot of things do happen that you don't want to wait until the bottom of the earth falls out before, like, you want to be proactive rather than, you know, take care of the baby, you know, once they've really crashed or whatever. So I think that, yes, some of the things that we do in practice are not completely academic. Thank you so much, Cyberrags. I really appreciate that. Magdalena asked me a question. At what age do we cool here? Generally 35 weeks. So kind of 35 weeks and above. And so she's talking about hypothermic therapy for HIE. Okay, we're at 32 minutes now. The plan all along was to do a 30-minute chat. And now we're going to go over to a 30-minute chat with the, you're so welcome. And now we're going to go over for a 30-minute chat with the members. If you are interested in joining the member community, we'd love to have you. It's a low fee. We talked about this for a long time, but we just kind of wanted a place where we can talk more freely, you know, about stuff. I don't want to get too personal when things are just like on the internet with everyone. And we've had some interesting back and forths about stuff. There's also a tip of the week for you, a neonatal tip of the week. There's debriefing videos after all the videos. I talk about kind of my own experiences or Ariana's own experiences in the NICU. I just randomly put up articles and stuff there. It's just been a really nice community. So if you're interested, then please join us. Otherwise, thank you so much for being, watching part of this and just watching any of our videos. We really appreciate you being here. Channel members, I'm going to have a little bit of coffee and then we'll get back to you all. Thank you. Bye. Oh, I can't seem to